Hello, everyone. Welcome to week number 5. It's Dr. Nyla, and let's jump into a really quick review of this week's content. We will cover ortho pretty extensively in this module. I do have the expectation that you all will be able to understand the epidemiology and causative factors of some common orthopedic scenarios. Please be aware of pathophysiology. You should be able to reason through and discuss the clinical presentation, know your diagnostic reasoning, know how to manage common orthopedic conditions, know when it's time to refer, and also know what a follow-up plan will be. And of course, I always want you guys to be able to incorporate medication management into each condition. It's very important that you guys know the minimum education for each of the musculoskeletal injuries, and those things are know what the red flags are, know when it's time to go to the emergency room, and the patient should know what the expected resolution of an injury is. So let's jump into bursitis quickly. Bursitis is simply the inflammation of the bursa. It can be caused by a direct injury or trauma. We are covering some occupational injuries this week, so think about your patients that spend a lot of time on their knees or elbows. These patients are at risk for developing bursitis. You should be prepared to manage these patients. Other potential causes for bursitis can be autoimmune. So think about your patients with rheumatoid arthritis. This could potentially be a reason that your patient develops bursitis. Sometimes bursitis does become infected, and I do have the expectation that you will know how to manage an infected bursa. We've already mentioned olecranon bursitis, which is the elbow and knees, but bursitis can occur in other places, such as shoulders, hips, and heels. The treatment of bursitis is pretty straightforward. We start with conservative management and then we gradually advance into things that could be more extensive. So the first step is going to be NSAIDs. So think of ibuprofen, naproxen, meloxicam. Those are potential medicines that we can prescribe. The next thing is joint protection or padding. Think about your work injuries. So we want to not only treat work injuries, but we also want to be able to prevent them. If things don't improve with simple rest and some ibuprofen, we may move on to joint injections. If things become infected, maybe the patients will need antibiotics and so on. The important thing is that we need to know when to refer. So if we have patients and we notice that things are not improving as we expect them to, we should know that it's time to move on to an orthopedic specialist. And if you do have the concern that maybe this is an autoimmune cause, we should be referring to rheumatology. Let's move on to gout. I can almost guarantee that you will see a question related to gout on your board examinations. You will see this in clinical practice. You will see this in the real world. There is always, of course, the chance that this may pop up on an exam question. But this foot looks exactly like gout. So you will see this red hot joint right there. The patients will complain that it is extremely tender. They will tell you things that their bed sheet is painful to them. When you touch this joint, it will be tender and it will be warm and it will be red. And here's the classic presentation of gout listed out for you. Always remember that typically your patients will present with a sudden onset. It's not something that gradually occurs over months. They will complain of sudden onset. They usually will have one joint that is painful, warm, swollen, or red. And the most common joint is listed here, and that's the one that I had in the picture on the previous slide. The treatment of gout focuses on stopping the current attack, and you want to prevent future attacks. For this lecture, I will focus on the acute treatment of gout, which is NSAIDs, colchicine, or corticosteroids. It is okay to combine colchicine with an NSAID or a steroid. It is our responsibility to make sure that our patients are well educated about the potential triggers for gout. I do ask that you look those up. Other things to consider is this patient taking a medication such as hydrochlorothiazide? That could be a potential trigger for gout. And are there any underlying medical conditions that could lead to an increased likelihood that this patient would develop gout. So please take some time to review that additional information. Let's move on to osteoarthritis. And guys, I'm really picking things that I feel will show up on your boards and things that I think that you really should be well versed on when you are in your clinical setting. The clinical presentation for osteoarthritis is that it develops gradually over time. It can affect one joint or multiple joints, and patients will complain of stiffness. Patients have pain with weight bearing. Patients have pain that is worse after they have been sitting for a prolonged period or prolonged activity. A clue for this is that after sitting for an extended period, if the patient gets up and walks around, that pain usually improves over an hour. So that's a hint, hint for when you see this on potential board exams. The treatment for osteoarthritis is listed here. Big things for you to know is that x-rays are not typically part of the initial workup with osteoarthritis. The history and physical are your initial diagnostic tools. The management of this will focus on things like Tylenol and NSAIDs. I see here on this slide, tramadol is listed. This is an old slide. Now, we don't recommend narcotics as part of the first line treatment for osteo. And I'm pretty sure that boards have shifted to this. So if you have a question that says, which of these medicines should not be given as first line treatment for osteoarthritis, and they list like acetaminophen, ibuprofen, naproxen, and then tramadol, the answer will be tramadol because we don't recommend narcotics as first line. We also recommend lifestyle management. So that is weight loss. Having excess weight is hard on your joints. So we do recommend weight loss for patients. We recommend exercise. Some patients we will have to refer for physical therapy or occupational therapy. Gabapentin maybe later down the line. Again, this is a really old slide. I didn't realize this was here. But gabapentin, tramadol are not going to be in your first line treatments. This is a quick image of different types of fractures. I will have these included in your supplemental learning so that way you can take a closer look at these and this slide as well. And let's look at some orthopedic red flags. These are known as the 5 Ps: pain, paresthesia, paralysis, pallor, and pulselessness. Don't miss this. If you see this in any of your patients, these are red flags, and just don't miss it. And I will make sure that you have additional information on this as well. We'll now move on to low back pain. You will see a lot of low back pain. There are many causes of low back pain. I have these listed here. Risk factors for back pain could be age, obesity, genetics, smoking. Smoking is something that accelerates degenerative disc disease. So that is something that we don't always think about with our patients with back pain. But smoking is one of them. And then obesity is that big one that people don't usually like to talk about. So the management of back pain will focus on treating the underlying condition. So if this is something that is weight related, we want to encourage weight loss. If this is something that is due to a work injury, perhaps we need to review body mechanics with the patient. If we think that there are systemic causes for that, then that will require some additional workup. We absolutely cannot miss red flags on the patient. Okay, so I'm going to review this here. Okay, things that you look for with this syndrome: bowel and bladder incontinence, saddle anesthesia, weakness or lower extremity paralysis, and sexual dysfunction. Every patient that comes in with a low back injury, you should have this listed in your chart. So you should write that this patient has no bowel or bladder dysfunction, no saddle anesthesia, no lower extremity weakness or paralysis, those things need to be included in your medical documentation. The management of the pain or inflammation, we can use Tylenol, we can use an NSAID. Again, the first line is not going to be a narcotic pain reliever. The big thing that we want to focus on is preventing future injury, preventing chronic disability, and we want to make sure the patient has mobility and a good quality of life. This is also additional information for you to review. So look at the different types of spinal abnormalities, know what their presentation will be and how we manage those. Additional study tips is that you should review osteoporosis. Super important. You will need to know when we screen, what are the risks for osteoporosis, how we manage it, and when do you refer. You should be able to manage sprains. You should be able to manage knee pain. So there's different types of knee pain, and there are some very specialized exams for your knee assessment. So make sure you know what those special tests are. So for instance, like an anterior drawer test, like what is it? How do you perform it? What does a positive test indicate? And then always with everything, be able to develop a differential list. And I believe that's the end of my lecture. I forgot to put the end here, but it's the end. And here's a reference here that's not already included in your weekly readings. Good luck, guys.